When we have to operate on a patient, we need to give anesthesia. Now we know there is spinal anesthesia and general anesthesia. What happens when there is difficult intubation? Normal circumstances, the anesthetist passes the endotracheal tube through this. Then there is something called video laryngoscopy. They intubate with this, and whatever is inside the throat is seen on the screen, and the patient is intubated with the endotracheal tube. But if you can't pass the endotracheal tube, even with the help of this video laryngoscopy, this is the endotracheal tube passed through the larynx to secure the airway during anesthesia. Now, if we can't pass this through the regular conventional way, then we do video laryngoscopy. Even then, if it is not possible, there is still a difficulty to pass this endotracheal tube. How do we do it? Let's ask our expert anesthetist how to go about and how to manage a difficult intubation case. Regarding difficult intubation, let's talk to our expert anesthetist, Dr. Anupama. Dr. Anupama, we were talking about difficult intubation. Now, this is the conventional laryngoscope for intubation. This is video laryngoscopy. This is fiber optic. Now, there are situations and challenges for you people when you can't intubate the patient, and you don't intubate, we can't do the surgery. So, please let us know when you use this. This is conventional, every day you use this. When you use this, and which is a critical situation for you to use this fiber optic laryngoscope.
Okay. So, as you said, I am Dr. Anupama, anesthetist, senior anesthetist practicing anesthesia for the last 30 years. And as you were saying, this is a conventional laryngoscope used normally for any general anesthesia to intubate the patient. And nowadays, like off late, we have got this video laryngoscope.
Luxury.
This is the luxury of having this, which is can be used normally for every patient, which is you will be more confident because you will visualize the larynx and intubate, and everybody around you can visualize, not only you.
That's
Just
nice.
only you can visualize it,
Yeah.
and everybody else can watch that you are in the larynx. So you are 100% sure that the patient is, tube is in the larynx. And this can be used for a slightly difficult airway where, like epiglottis, larynx is just below the epiglottis, and only a little bit of epiglottis is, larynx is seen. Very small portion of the posterior larynx is seen. In that case, this can be used, and even this can be used for obese patients with short neck.
Beginners can use this.
Yeah, it can be used, but a slight learning curve for this is very small, and because it's almost like a conventional laryngoscopy. Only thing is you should have a slight skill of elevating the epiglottis even before you go to the base. Then only you can visualize the larynx completely. Otherwise, maneuvering the tube through to the larynx is difficult.
Yes.
You can visualize it, but you won't be
have
able to maneuver.
So that
and
lies the
yeah.
expertise.
And another thing is like with this, to intubate or to maneuver the tube through this, we can use a stellate and use it regularly. Generally, it is done with stellate because otherwise nobody will want to struggle with this one. Generally, use the stellate and pass the tube. So
You can't do with that.
you can't do that. You cannot visualize anything.
Yeah.
And there are conditions which is very difficult even for video laryngoscope or any other method. And in that case, like short neck, cervical spine abnormalities, or morbidly obese patient, and facial-maxillary surgeries, neck tumors, and any facial jaw tumors, where the opening of the mouth, jaw, yeah. And where you cannot open the mouth opening is severely restricted. You cannot cause any of these things.
Yeah.
So in that case, fiber optic laryngoscopy is very important, and it's very useful and it's life-saving.
Well, you told us about the video laryngoscopy. Now you have told me about those difficult indications for fiber optic laryngoscopy. Now please tell me how you do this.
Yeah.
It looks so challenging.
Yeah. See, this is mainly done in awake patients where you expect.
Awake.
Yeah.
Okay.
Awake patient where you expect difficult intubation. Awake patient is mainly because if you sedate the patient, your all the muscles of the neck will get relaxed and it will cause more difficulty for intubation, and it is
Spasm.
no, not spasm.
Huh?
It is relaxation and difficulty,
Okay.
and patient won't cooperate.
Yeah.
And the challenge that we have is securing the airway.
Yes.
Securing the airway is challenging. That's why we need this, and that has to be done awake, so that you will be patient saturation is maintained. And this fiber optic laryngoscopy is used mainly in difficult conditions where where mouth opening or neck movement is severely restricted, and this is done awake. Awake is mainly because you can secure the airway when the patient is breathing on his own, and his respiration is not suppressed because of sedation or anesthesia, where there is chances of saturation being dropped severely because of difficulty in securing the airway. So how do we do this?
Yeah, because see, you said saturation will drop. You said patient may awake. How do you do this?
Yeah.
Patient will retaliate, or
Yeah.
patient will refuse to even cooperate. How do you do it?
So main thing is counseling. First, you have to do a good pre-anesthetic checkup and explain the patient what are the difficulties you may encounter during the anesthesia, and we should tell him what are his conditions, why we are doing this fiber optic laryngoscopy, and then when we should tell him that we are going to block his airway and he will not have much problem, he just has to cooperate a little bit. And if you counsel him very well, patient will cooperate, and then we give airway anesthesia, airway block.
Where do you give this?
Airway block is mainly given in cricothyroid. Cricothyroid
Okay.
block is given in cricothyroid membrane.
Okay.
It is a small depression that we feel it as we go down below the hyoid membrane at the level of C6. So in that you give about 2 ml of xylocaine and anesthetize patient at the level of C6. You identify the cricothyroid membrane by a small depression just below the hyoid membrane, and go through the neck. As you enter the cricothyroid membrane, you feel a give way sensation and the free flow of air is established, and then you give about 2 ml of xylocaine. Patient will cough, and as the patient coughs, the local anesthetic spreads and it anesthetizes the
Okay, that is the trick.
Yeah.
That is the trick. Okay.
anesthetizes, and ask the patient to open the mouth as much as he can and spray the posterior pharynx with 10% xylocaine.
Okay, that is
So,
another
yeah.
xylocaine which you are giving,
Yeah.
where the patient does not feel the gag. Yes.
Yeah. And then you start your procedure. You
Okay.
keep talking to the patient, telling that what you are doing, and
Okay.
keep on doing it slowly. He will definitely cooperate.
Excellent. This is something really beautiful and very well explained, Anupama. Very nicely you have told us about the normal intubation, the video laryngoscope intubation, and your fiber optic intubation, which is all three are real airways of the anesthetist,
Yeah.
and you facilitate this so that we operate safely.
Yeah.
So thank you so much for your enlightenment on these aspects. I'm sure everybody will be benefited. Thanks a lot.